All right, we'll just go from right now. So this week 6, we're in the middle. We're over the hump now. It's like Wednesday hump day. This is hump week, as we call it because we have 12 weeks. I did turn on the homework grades just to show you how they do affect your grades. I really don't have many problems with this class not turning in NCLEX or not turning in CJ Sims. One missing, you can get away with it. But when you start getting 2, 3, that's 2.5%, 4%, and of the grade, and it does add up. So let's go over, first of all, before we go into this week, what we're doing. Remember week 8, you have that pediatric assessment project. Make sure that you let me know what you want to do. You do not have to take one off the list. The list is there as a guide. If you know a child or your sister, people or you saw in the hospital a diagnosis that really interests you, that's what you should pick because it's going to spark an interest and you want to learn about it. I have many students doing it about their own children, trying to learn a little bit more about their children and diagnoses. Okay, so whatever works. 3 parts. One is a 250-word paper. Second part is that very long form on the modules, and it's mostly circled down the assessment. It gets tricky when it goes into the theorists and then in your NANDA diagnoses. If you turn them in early, as I said, I will tell you if it's right or if it needs tweaking. I'll tell you what to do, and you could resubmit. You can submit right in the modules. There is unlimited submission. So you can send it in. I'll tell you what needs to be done. You can return it in because it's 6% of your grade. So if there's any questions, let me know. Again, I need to know what your diagnosis is so I don't have all of one. So this week is a week we're talking about children with hematologic, immunologic dysfunction, and we're going to go into some cancers, leukemia, lymphoma type stuff, brain tumors. We're going to go into that, and of course have our Kahoots. Remember, there's a CJ Sims, and there are NCLEX questions always, because next week will be exam. Now, I do give a review tomorrow at 2 o'clock Eastern time. Again, I will post the recording. I usually post it fairly quickly, especially the reviews. And if you need even quicker than it shows up on your announcements, you can always go to my YouTube channel, Professor Bogart Pediatric Nursing. So it's always there, ready and available for you. The study guide, I've gone over it very carefully again, and I believe most is there. I highly recommend you study the study guide, test yourself with the Kahoots that I've done for weeks 4, 5, and 6, and then look at the PowerPoints. There are questions that come only that are on the PowerPoints, just to look at it. And that's how I would recommend you to study, okay? Just don't do Kahoots. Just don't do study guide. It's a combination, okay? A little bit of everything. Any questions about anything? All right, that quiz, one of the questions I really wanted to emphasize, not all of you got it wrong, but what increases pulmonary blood flow? Is anything that lets blood go back into the right side, right? Right side goes up to the lungs. So any hole that lets blood go back into the right side, into the lungs would be it. So an ASD or a VSD, even a PDA, those would be your answers, okay? All right. Let's go ahead and start with our PowerPoint. Again, stop me if you don't understand or you have a comment you want to say, I welcome them. So chapter 43, and we're also going to do chapter 44 this week. So hematologic, immunologic dysfunction, how do we go and how do we assess these things? Well, Of course, history and physical is going to tell you something. Um, and a simple CBC has white blood cells telling you is there an infection? Are they too high? Or are they too low? Either of them will tell you stuff. Also looking at neutrophil counts, right? Neutropenia is not enough white cells, and I know those children are at risk for infection. Um, then you've got your hemoglobin hematocrit that's looking at, do you have enough, iron and oxygen going to the cells? And then platelets is the other one with bleeding coagulopathies. So we're going to be going over all of those differences. Now, many a times children come in that all of a sudden the parents say they have no energy, that they're just really tired, really poor, feeling blah. We know that red blood cells carry oxygen and iron. That gives body the nutrients to be able to have energy to get up and do what they need to do. When those levels go low, it will be evident in the way the child is. And there's many reasons why it could be low. We know that toddlers are probably at the highest risk for iron deficient anemia because they don't eat right, because they eat little bits of stuff. They don't eat all the good foods. And we're now not giving them breast milk. We're not giving them iron fortified formula or iron fortified cereals. Those things now we're just eating regular food. So that's a high group of iron deficient anemia. And we know children with frequent infections, we're going to find out why. And if they're bleeding, whether it's ecchymosis, petechiae, or just gross bleed. Anemia is one of the most common blood things that we have. And as I said, red blood cells are important. Your body needs oxygen and your body needs iron. It gives them the strength and it gives them what they need to be able to be energetic and do what it has to do. We know there's all different reasons, and I'm going to go into them. Why? Whether they're destroyed too quick, they're not made right, all of these things. And in children, we consider probably hemoglobin less than 10 is that we consider anemia, except in infants. Remember those infants, about 6 months, they'll haven't started making their cells yet. So sometimes an 8 or 9 hemoglobin is acceptable as long as the child's active, gaining weight, has enough energy. So anemia. Get a child come in, they're feeling tired, they look pale. You saying, is it anemia? You don't have that complete blood count yet to look at. Listen to the heart. You're going to hear a swishing murmur. Now, normally cells fill it up and there's no banging around of cells. And it goes through all of the heart valves and you don't hear a sound. When it becomes more liquid and a couple little cells in there, you hear them bouncing and you hear almost as a murmur in there. And that's going to tell you, yeah, it is absolutely that, even before you see a CBC. We know a heart is trying now, all right, body's not getting oxygen, it's not getting iron. So the heart says, let me try, beats faster. And it works hard. And then it gets to the point where, I quit. I've had enough. I can't work this hard. And you go into cardiac failure, right? Just like you, when you're tired, you sit down. Well, the heart's going to do the same thing. So no oxygen, no iron. You're going to have cyanosis and, of course, growth retardation. Younger kids could be cognition. It's not going to be where it should be. Now, this is right from your book. Decreased red blood cell production, an increase in blood cell loss, and an increase in red blood cell destruction. So the production, the loss, or just it destroys itself. So let's just look from the left to the right. So nutritional, I've already mentioned iron deficient anemia, not enough iron in the diet. And the other one we look at is B12. B12 is the intrinsic factor, right? That has to do with carbohydrates, and it starts in the stomach with digestion. So wouldn't be enough B12. Then we go into the bone marrow is just not producing what it should. It could be due to leukemias, right? Cancer. And it also could be due to something called aplastic anemia. So we go forward. I'm going to describe what those things mean. Of course, increase in red blood cell loss. Well, obvious bleeding somewhere, right? It could be vomiting blood, one of the things that actually children come in with, and we diagnose these leading coagulopathy problems, is nosebleeds. Children come in, they have a nosebleed. We say, okay, you just had a cold. Paint your nose with Vaseline, keep it moist, morning and night, and that should work. And then they come back and it's going again. And maybe not it's hemophilia, but it could be something, this ITP thing. And we're going to go into what that is. Then we go into increased red blood cell destruction. We've heard of sickle cell disease, right? There's sickle-shaped cells. They don't last long and they're destroyed. And then we have something called thalassemia. I call these the rectangular cells. Same as sickle cell, as in they don't last long. And then, of course, it could be something immunologic, could be drugs, toxic, sepsis, something that's causing the destruction. So how do we diagnose anemia? Well, history, physical, and let's do the CBC. Now, if a child comes in, obviously, their heart's struggling, hemoglobin hematocrit's low, our priority to give some blood to that child. I know sickle cell children are always coming in because they have increased cell loss. Their hemoglobin hematocrit is 5 and 15, 6 and 18. If it's 7 and 21, I'm pretty happy. But those children in the emergency room, we start blood. They can't even wait till they go up to their rooms. So that is your immediate thing. Now, all it is, taking care of the symptom, but not the cause, right? We know nutrition is what we give for any of those nutrition type of things, your iron or your B12 deficiencies. So we're going to start at IV, give some volume. The heart likes more volume in it. And they say, put on oxygen. Now, I say that's controversial, and it is. If you don't have cells to carry oxygen, is extra oxygen going to help? So, well, it might. So that's why we put them on. But the biggest thing is calm the child down. Stop them from being upset and stressing and screaming and crying. Or an older kid, bed rest. Don't overwork your body. Rest it so you're not burning oxygen and energy. Do an assessment. How old's the kid? That racial or ethnic background. Well, sickle cell is African American. Thalassemia is people from Mediterranean Sea. So that might be a clue there. Get that history. And then rule out the obvious bleed of a GI bleed. Always do a stool for occult blood. It could be an ulcer. And yes, kids do get ulcers. Or it could be some sort of bowel, ulcerative colitis, and it's bleeding. Something's going on. So always do that. Always, again, prepare the child. You want them to not work and scream and cry. They don't have oxygen, right? Do everything to keep the kid quiet. Let that oxygen and iron they have, just do its job without having to overwork. And of course, we always try to prevent that complications. So iron deficient anemia is when you don't get enough iron in the diet. As I said, this is mostly toddlers because they're not eating right, because we're not having, again, the iron fortified cereals and formulas and all of those things that we're giving when they're infants. Now they have to eat, their nutrition. Also, look at that adolescence. Adolescents tend to get a power bar, a bottle of water, go for the day, and not eat, and they're not getting nutrition. And they're more at risk, adolescents and your toddlers, both of them. Milk babies is talking about those babies that they only give whole milk to. They're not giving formula. So they're not getting all the extra vitamins and iron that you would with the iron fortified formula. That's what that means. So how do we correct iron deficient anemia? Well, diet, that would be easy, right? Or iron supplementation. Remember, iron supplementation in children is usually liquid. It's brown, it stains the teeth. We also know, what about iron? It is dissolved and started to break down in the stomach. The gastric acid breaks the iron down and makes it usable for the body to use it. So If you can take it with orange juice, another acid, it helps break it down and they can have it. Never with milk and never with meals. It should be before meals or at least 2 hours after, and through a straw because you want to keep their pretty teeth white. All right. And then we know if they're not going to have their iron, there's always that iron dextram. And remember, that is a deep IMZ track because it burns and we want to lock it in there, not just a regular IM that will ooze out. It will stain the skin too. And if they're getting, let's say, weekly injections, their whole butt or legs, wherever we're giving it, is going to be all stained. Okay, sickle cell. We've all heard of it. We know it's African American or Native Africans. If two parents have the trait, I mean, not disease, they just are carrying it, they each of their children have a 25% of having the disease. That goes almost with any of these things like cystic fibrosis, sickle cell, same thing. Have the trait, both parents, 25%, each child will have the disease. Now, let me explain sickle cell anemia in a way that might help you understand why we do the treatment that we do. So, you have a blood and you have all your cells in it. Cells are, yes, they're weird shaped. What happens is the blood, they go down the vessel and then the vessel bifurcates. And usually a sickle cell will go right on that bifurcation. And then everything backs up behind it and nothing goes down, lower it. And it gets swollen and then it starts hitting the nerves. It's painful. And then below becomes numb because there's no blood going down lower than that. So the vessels are holding it in there tight. So how do we treat sickle cell anemia? Well, you're going to treat the cause. The vessels are too small. The sickle cells can't get through. So we need to dilate the vessels so the cells can go through. So priority, start an IV, give a bolus of normal saline, dilate those vessels, and you're going to take that little bind up of where all those cells are making everything painful, and they're going to start going through, and it's going to decrease that swelling. Also, heat, it's going to dilate it too. So that's what sickle cell is, all right? It's just a cell gets caught and they all back up and it gets swollen and blood can't get through. How does this happen? Well, it is an autoimmune disease. So stress is always number one that causes it. But anything that increases body's need for oxygen or alters transport of oxygen. How about going up in an airplane? Do you think that could be a problem? Cabin pressure, right? What would you tell a sickle cell child? Drink more fluids before you get on the plane. Make sure your cells are big as they can be and drink during the trip. Simple as that, right? Trauma, ecchymotic area decreasing, squishing on those vessels. The vessels are smaller. Guess what? Cells get stuck. It's going to cause it. Infection, always at insensible. Water loss, again, it's that size of the vessels with the fever. Again, as I said, stress. And then we know that if we're getting dehydrated, it's getting thicker blood, and it's going to cause that area to just clump up. We're doing sickle cell screenings on all newborns today. We didn't always do these things. So kid comes in complaining of left knee pain, swollen, hot, red, and extremely painful. It is a 9 out of 10. They're crying, they hurt. What is your first thing? Start an IV and give fluids. Now, on my other hand, I have the pain medicine, but this is treating the symptom. The IV fluid is treating the cause. That's why that's priority, okay? Then, of course, we're going to put heat on it, so it dilates it. You're doing everything to make those vessels bigger, to get rid of that clump of cells, to get it going so we can decrease the pain. Usually, sickle cell kids come in with fevers. They say any, and this is any, could be an ALL, leukemia, CF, sickle cell, anything autoimmune with a fever of 100.5, they are told to call the doctor. Remember, they don't have an immune system. They're immunosuppressed. So a little fever could turn into a big fever, and you call it sepsis and death, okay? Also with sickle cell, of course, we're going to be looking at those electrolytes, potassium, and we're going to be giving, if their hemoglobin hematocrit or low blood replacement, they usually come in extremely low hemoglobin hematocrits. 5 and 6 hemoglobins are not uncommon in any age child coming in with sickle cell. And of course, we're going to give them their dose of IV antibiotics in the down immediate treatment if you're in the ER. Now, how do we manage sickle cell when we know? Well, from 2 months to about 5 years old, we give 1 penicillin dose a day. It's called prophylactic. We do these for children born without spleen. It just helps the immune system until the body can make its own immune system, right? Young kids don't have really big immune systems, so they can get infections and sick really quick. So that little antibiotic once a day, not twice a day, like if you get an infection, it's just enough to keep infections away. Also, we're going to be monitoring the retic counts, making sure that bone marrow is working and producing cells. And of course, that blood transfusion is for that ischemia and to help the heart. Now, there is no cure for sickle cell. It's just you being on top of it, knowing if you have a fever, you need to get help, keeping hydrated. It can be normal children. But again, if they're going to be out playing sports, make sure that they are absolutely hydrating the whole way through, okay? And we know what's going to usually cause death of the young children is those bacterial infections. Why? They don't have an immune system, especially the young kids, right? So that is usually what gets them. They don't get care, antibiotics on that little 100.5 fever, and they can live a good life. So educating the family, early intervention for what they see, give the penicillin, and respiratory and stroke problems. Why do you need to recognize that in sickle cell? You can sickle cell in your brain, in the blood vessels there. So if they have a headache and they're sickle cell, you better think neurologic. This could be a stroke almost happening, okay? Or chest, it could be in the heart. Now you're looking for a myocardial infarction because now you could clot off your carotid arteries, right? So again, treat the kid normally and do everything we can to not have a sickle attack. All right, the other one that I said, thalassemia. Well, thalassemia is when you have what I call rectangular shaped cells. And they burst. They die and burst. Well, what is inside a red blood cell? It is oxygen and it's iron. Okay? So let's remember that. We know it mainly affects descendants of people living near the Mediterranean Sea. So they're short lives RBCs, they burst, they release oxygen. So you're going to be tired and fatigued. Also, hemoglobin hematocrit is going to be low because there's no life on these red blood cells, and it's spewing iron into the body. Now, there's 4 types of thalassemia. You don't have to know all the types. What you need to know is the Cooley's anemia. When you are tested on, it is assumed that's where you are, okay? But there are little minor carriers, a little mild anemia, but usually what we call is the Cooley's anemia. And this is somebody whose cells are bursting so much, they need blood transfusions to survive. We can't make the body produce more cells because they're going to burst anyway. And what happens when they burst, they're bursting, throwing iron into the system. So much iron from the cells that they're going to need iron chelating drugs. Okay? Iron chelating drugs like desferol, it combines the iron and it excretes it out through the kidneys, but it can become toxic. That's how much iron that you would see. Now, sometimes at birth, we're not going to see it. Cells are normal, they're from mom. But then we start seeing about 6 months old, well, about 6 weeks old, you're going to see the cells start changing, and we're going to start seeing them. They're going to be becoming anemic. Okay, they're not getting oxygen. they're not getting iron, they're going to have cognition problems, and they're not going to grow. Okay, see, all that nutrition is all feeding in the same thing, whether through blood or through formula, right? So our management, blood transfusions, because we need to keep the hemoglobin level up as high as we can. And if it's going on like that, you will be taking either oral desferal, or they can do something called apheresis. It is like a dialysis, but it only pulls off a component of the blood that you want to come off. And in this case, it will remove the iron. So how do we care for it? Well, compliance with that iron therapy. I mean, too much iron can cause seizures and death. So we really need to keep up with that. Again, these kids are in and out blood transfusions. It's hard to live a normal kid's life with this disease. So keep the kid calm, and with all of these blood transfusions, there's going to end up with all of these little antigens and antibodies in their blood, and could create a lot of problems. And can we get the blood that you need as it goes forward? And of course, blood transfusion reactions yes, they're going to happen. Now, they can live, a pretty long life if they have a blood type that is common. But what happens is this: think about thalassemia. So you get your blood transfusion, your hemoglobin's here, and then they start bursting. Your hemoglobin goes down there. Your heart starts beating, beating, beating. Then you get the blood. So you're on this yo-yo of heart beating. It's okay. Heart beating, it's okay. So heart disease is one of the things that we see. And it with all of this iron and oxygen deprivation, multiple organ failure, and a lot of times they'll try to remove the spleen from producing these cells, but a lot of times immunosuppressed again, they do this post-splenectomy sepsis. And maybe a bone marrow is a cure on this. They still don't really know. Okay, aplastic anemia. This is one, and we usually think of it as a pancocytopenia. That's the one that we consider with aplastic anemia. And it's profound anemia, low hemoglobin hematocrit, leukopenia, low white count, and then thrombocytopenia, and then P platelets. That's how I always remember, or thrombus platelets, low platelet count. And this is something that we had treated very, very similar to leukemia with chemo, immunosuppressive therapy, bone marrow transplants. But again, all of your hemoglobin, you're low, you're apt for sepsis, you're apt to bleed. It's like a really difficult diagnosis. So hemostasis, bleeding, coagulopathy, clots. Now hemophilia, bleeding disease, it's X-linked recessive in most of the cases. And in the blood, there's many things you need in order for bloods to clot. You need factor 8, factor 9, van Willebrand factor, and platelets, and a lot of other stuff. But those are the ones that we're going to discuss. So A is the most common of all, factor 8. Factor 9, they call it Christmas disease, or factor 9. Just means factor 8's okay, but factor 9 don't work. And then a scientist named von Willebrand found one of the factors, and they say with factor von Willebrand and 8 also hemophilia. So what happens with hemophilia? You get cut or you bruise and the bleeding doesn't stop. It's prolonged, okay? Now, if it's a nosebleed, it's just going to keep going. If it's a bruise, you fall down, hit your knee, and the bruise is swelling up. The knee's going to keep swelling up with blood because it's going to keep bleeding. So, we're going to see things like hemoarthrosis, which the knee's going to swell up, bruising in all these places, or we're just going to see they're bleeding. You get cut and they're bleeding. Again, in an ER, they come in and they want to be treated, or even in a doctor's office, they're going to be taking a whole bunch of blood tests to find out what's going on. Why are you bleeding so much? They'll always do the PT, which would be like for Coumadin, or the APTT, which is usually used to check heparin. And then they're going to do the factors if we're thinking it's now some sort of hemophilia going on. There are other things, as I said, parathormone or fibrinogen. Those are other levels. But in hemophilia, the one thing that we're going to see, because it takes about a week for factors to come back from that special lab, so we don't have it. But what we see initially is a prolonged PTT. But usually the normal is 40. You'll probably see 300-400. I mean, it's going to be a real obvious difference. And then you say, okay. So what do we do? Well, once we know what factor we have to get, we're going to be doing some home infusions. Now, factor 8 comes in a box and it's 2 syringes. One has liquid in it and one's powder. And you have to take the liquid, put it in, and very gently rotate it and mix it up. Put it into a syringe, tubing, and slowly push it in. I've actually watched a father and a 9-year-old in the ER. They asked me if they could do it. He'd come in, couldn't get hold of his hematologist, and he had fallen down, and it was a knee that was getting really swollen. And the ER physician said, yes, give it. And the father said, please, can I do it? I'm like, you do it at home. Let me just watch, okay? And I had an orientee with me, a brand new nurse, and watch this father do it with such great care and really good technique. And the son, sticking the little butterfly, held it, the father pushed it in, and it was done. It was really, I was really impressed that this father did it so well. So at home, they will give the factor. Now, desmopressin, we're going to learn next week. It's also used for diabetes insipidus. We'll go into what that is. But desmopressin, we can give IV or nasal spray. Those little milder ones, usually they give them the spray and that will work for it. So care management. Well, I have price down here instead of just rice. And the reason is this. Sometimes you get some young children, like toddlers, that were just learning that they're hemophiliacs, and it can happen. So the first thing is you got to protect that environment. Think about a toddler falling down and banging themselves all over the place, going up against a coffee table with a sharp edge, and they cut themselves. So really protecting the environment for that child, that would be the first thing we do. Again, good dental care, being careful because your teeth can bleed, right? So soft toothbrushes. And then, of course, rice. Sit down, put your leg up, compress it, and put ice on it. So rest, ice, compress, and elevate. And if you have that home infusion, give the home infusion. Any doubts, of course, they would call the physician to be sure, like that child did. Our concern with hemophilia is that if they, especially children, they're always going to fall down. They're always going to get bruising in knees and hips and toes and arms and elbows and whatnot. And blood in the joint sac causes irritation and destruction. So they can end up crippled if we don't stop that blood quickly and get rid of it. So again, preventing that. You know, when we see the bleeding, treat it right away so we can get rid of it. So they can live pretty normal lives, but they're not going to be playing football, right? This would be a child, maybe to be on the swim team. That'd be a great thing, or diving, something else. But they can be pretty normal at that. They're working on gene therapies, of course, but it's not quite there completely. All right, another bleeding problem, immune thrombocytopenia, and the last name is purpura, ITP, P for platelets. This is when a child comes in whose mom says, this child has bruises here, there, and this little tiny bruises, purpura, on the legs. And this kid only plays video games. He's not out. He hasn't ran, falling down. So why does he have these bruises all over him? On evaluation, we find out they've probably had some sort of upper respiratory or some infection recently. And that's when it occurs. So this can be cured. Sometimes if we last too long with it, it can become chronic, but most of the time it's acute. We can treat it and we can get rid of it. So what do we need to know as nurses to take care of it? Well, these children bleed. Platelets are less than 20,000. 10,000 is not an uncommon. What's the normal platelets? Over 100,000. Okay. So what we do is we start an IV and we give IV immunoglobulins and something called anti-D antibody. And usually when they're first diagnosed, they're put in the hospital and they're monitored. So nurses, what do we do? What do we need to look for on these children? Well, number one, it's bleeding precautions. Bleeding precautions is, if at all possible, these children will be getting daily CBC counts to look at their platelets. Is this IVIG and anti-D working, right? The only way to know is by checking the CBC, which is a platelet. Usually we can pull that out of the IV if we're very lucky with it. We can do it that way. So no venipunctures if at all possible. We're going to be watching them for bleeding, their gums, their urine, their stool. We're going to be looking for bruising, ecchymotic areas, new ones, right? And we're going to be looking at those platelet counts at CBC every morning. And then corticosteroids if nothing's going on. They're not improving, corticosteroids will be given, and that is your treatment. It's something you need to know. Now, I mentioned epistaxis is one of those things. I can tell you, I remember 3 children came in with nosebleeds, epistaxis, and it ended up being ITP. So it is one of those telltale signs. So if the child is with an epistaxis, this is the treatment that we say, and usually this is an NCLEX question. First of all, the kid sees blood, especially a preschooler, they're going to die. They're screaming, yelling, going crazy, heart is beating, and they're bleeding even harder, right? So number one, calm the child down. If it's sitting on mother's lap, wherever it is, let them be. Take your thumb and forefinger and pressure on the soft lower part of the nose, and we lean them forward. And that's, we don't want the blood going down their throat and their vomit, vomit it later on. So this way, so actually it will spit out through their mouth if they need to. Hold it for 10 minutes. And after 10 minutes, if they still bleed, they need to go to the doctor or to an emergency room and find out why. Maybe it needs cauterized, nasal tampons, whatever it is. Now, immunological, HIV/AIDS. Let's talk about the first child that could get it, and that's your infants. And usually through the mother has HIV, and we're worried about passing it on to the infant. Now, if the mother is up to date, prenatal care is being done, they can start this heart therapy at 22 weeks and then do it after birth. And whatever we do for HIV on an infant is always just to improve their immune function. Remember, they're only born with mommies. Mommy doesn't have one. So we need to get those antivirals into that infant to improve their immune function, okay? Now, does it mean a child born of HIV mom is always going to be HIV? And the answer is no. One of the things that I saw at the clinical site was triplets. One child had AIDS, one child had HIV, and one child didn't have anything. All from the same mother, triplets. There are children born HIV and 0 convert by 1-year-old with good care. All right. So we need to improve those immune functions. And that's how we do it, by giving those antivirals. Pneumocystic is the most common infection in children. And we know pneumocystic is, again, early stage when their immune system's working at 3 to 6 months. So again, it's teaching. HIV adolescents, teaching safe sex. Absolutely. So we give for what? For immunological disorders. As I said, blood transfusions. Sometimes we give PRBCs, is they're packed. If we have a volume loss, then they're low through a hemovolemic shock, as in they lost blood like crazy. We're going to give whole blood. We want to give as much as we can as with the volume in there. Always remember in blood transfusions to follow the hospital policy. As I said, apheresis. It looks like that machine sitting up there. Very similar to that. And they take the blood off, it goes through the machine, it removes what you don't want. In case of thalassemia, it removes the iron and puts the rest of the blood back into the body, okay? And then remember, bone marrow aspirations will be done looking at the cells. What do they look like, right? Looking at the marrow. Now, has anybody ever seen a bone marrow aspiration? I want you to know it is, as they take that blue thing, they put their hands on it and they push and turn it, and you can hear crunch. Now, they do numb it with EMLA. Wait for it, works. They do deep infiltration with lidocaine, but it's still going to hurt. Again, with children, don't lie. It's going to hurt a little bit, but I'm going to do everything I can so it won't. And I'll hold your hand. You know, sometimes that's all they need, distraction. Many times these bone marrows are done under sedation, but they're still a little aware in there. So when both parents have sickle cell trait, what is the chance that each of their children will have sickle cell anemia, the disease? Anybody? It's 25%. Okay. Both parents trait, every child has a chance of 25%. So let's go into those cancers, neoplastics. We know half of the cancers are blood forming organs, leukemia, and lymphomas. So, what is leukemia? I like this definition here. So let me just pop ahead a slide for a second. Leukemia is the unrestricted proliferation of immature white blood cells in the blood forming tissues. And what does that mean? Well, cancer gets into the white blood cells, eats them up, and they're not formed and they don't work. So, what does that mean for the body? That means the body doesn't have an immune system, doesn't have white blood cells that work. So these children are really those kids you have to be really good with technique and hand washing, right? Leukemias is either ALL, the lymphocytic cells, or AML, the myelolytic cells. Now, ALL is the easier of both to be cured. AML is a little bit harder. It just seems it needs a little bit more treatment. Down's kids are at higher risk for leukemia. They're at higher risk for congenital heart defects. They're at higher risk for hypothyroidism. These are things that we'll be monitoring with Down's children, okay? Something you need to know. I've seen questions on HESI regarding that one. Now, 2 to 5 years is when we usually find leukemia in children, and survivability today is so great with all the advances. So, what would you say? Well, I'll give you an example of my neighbor. Now, this one was a teenager when it happened, but it was so classic signs and symptoms. Felt like she had the flu, running a fever, had really bad knee pain, and she was bruising, and she felt horrible. The parents brought her into the emergency room, and they, of course, did a CBC. And what they found, and they did this blood smear, it's called, and they found the cancer cells in her CBC. Her initial white blood count was 0.01. Isn't normal like 5 to 7 in most labs, or such about there? So no immune system. So, of course, she was admitted. Now, they did a lumbar puncture. We're looking at that central nervous system. Is there any involvement? And of course, they did that bone marrow aspiration, looking at the cells at the bone marrow. And again, I can't tell you 100 times, please tell the kid it's going to hurt, because once you lose their trust, they don't trust you again. So they insert a port or some sort of long-term intravenous device. They use a port a lot. And what is a port? Well, there's things that hang out with tubing on the chest central lines, right? Well, this is under the skin, and it's like this little round metal thing. And in the center, there's a place where we put a needle, and that just, you pull it and you aspirate and you got blood. And it's really easy to work with. Parents are taught how, if they need to come in, kids having a fever, whatever, they put cream on it. So by the time they come to us, they're numb. We can just access it, get the blood we need, et cetera, et cetera. So ports in, now we're ready to do our chemo. Now there's 4 stages, but the first stage, induction therapy, is the most important. It's 4 to 6 weeks of intensive chemotherapy. It could be 1, 3, whatever, combination, whatever the new vogue chemo is, right? To treat it is what they give. Induction's goal is to achieve remission. That means cancer's gone, right? Well, there could be some hiding. Little cells can hide here and there. They also will go in their central nervous system and give it intrathecally too. Put it right into the spinal column. Get the meninges, the spinal cord, all, with chemo, making sure there's nothing in there hiding, right? Then they're going to do this intensification or consolidation, where they're just making sure, again, that that cell is not, trying to hide and think about later. And then, of course, they do that maintenance to make sure they're in remission and that they stay there. We know that induction is the worst part, right? Now, one of the cures is a hematopoietic stem cell transplantation. Now, there's 2 types, and this is how you're going to remember it. So you either can have autologous, which is my own cell. Automatically, mine is the best, autologous. And then there's other stem cells that they can use, and it's all the others, allogeneic. Now, of all the other, the best would be from a sibling, but it doesn't have to be blood type the same, anything. It can be anyone giving stem cells that can be infused. We know mine is the best, my sibling is the next, but all the others can work too. So automatically mine, autologous, all the others, allogenic. So in leukemia, again, this is quite a long, thing that's going to be going on. Always prepare them in a case, this child's having pain, and they have a lot of bone pain and whatnot, almost like fluish, but even worse pain. Make sure your pain, that you're up on that. And then, of course, they are immunosuppressed, myelosuppressed. Be careful of infection, hemorrhage, and anemia. Now, anybody who wants to be a pediatric oncology nurse and get certified in chemotherapy, this is the one that can get these bonuses of $25,000 sign-on bonuses for 2 years. That's how they want these nurses, and they want them well. So if you can work with it, it's a great field to try to go into, okay? Now, they always say, well, many of these kids die. Well, adults die too. And it's not that a kid died on you, it's that what did you do for the kid and the parent when they were alive, right? And when you make a difference, it makes it a little bit easier for everybody. I was just looking at an old Facebook that I changed it and went off of it for a while. I have several parents on every Nurses Week and every birthday tell me, to Chris's favorite nurse, I'm always grateful for you. This is 20 years later. So you can make a difference, even if they die. And it is a nice feeling to know that you did make a difference. So prognosis, well, what was the white count when I, came in? Was it ALL, AML? If you're a boy or girl, and what blood type are you? Are you AB negative? Are you this weird blood type? Well, that one's going to be harder to transfuse you, platelets or whatever you need, right? So A positive, O positive, you're good. So that makes a difference. Now, cancer. We can have chemo, we can have radiation, we can have surgery, one or all of them. Signs and symptoms, I've already said them: pain, fever, ecchymosis, petechiae, bleeding, and then lethargy, weight loss, general malaise, anemia, because those cancer cells are eating the good cells too. And then lymph nodes can get enlarged, and sometimes even vision can go. Side effects of treatment, again, you are absolutely without an immune system, immunosuppressed. And what do we look at? We look at neutrophil counts. Now, neutrophil counts, whether you're in leukemia or you have any other disease, if you see a child with a neutrophil count 500, lower than that, this child does not have an immune system. And if they have a fever also, you better get the doctor and get antibiotics ordered. This one will go into septic shock very quick on you. So neutrophil counts, remember that. It's part of leukemia, yes, because of the white blood cells, but it can happen in any disease, just for you to know it. So prevention of infections, seeing that, oh my goodness, we have a fever, starting those antibiotics is going to help septic shock. We know because it's eating cells and platelets and everything, there's going to be bleeding. They're going to be getting blood, the platelets, whatever, protecting them from injury. They shouldn't be out riding skateboard, right? These things shouldn't be done, no contact sports. And we know anemia, absolutely common during that induction. You're killing the cancer, but it doesn't mean red cells aren't going to go too, right? It gets a little bit of everything. And we know there's going to be anemia. Why? Well, you're going to see a kid tired, less energy. That is a common diagnosis there. It's a nursing diagnosis. We know there's nausea and vomiting. Do you know when I became a nurse, they had to vomit before I could give an antiemetic? Today, we know if we get it before they vomit, it works better. But this is one of the progressions of nursing. They don't want to eat either, right? So monitoring intake, monitoring height and weight is going to tell you if they are getting enough nutrition, right? And what sort of diet. We'll give them the richest, fattest, highest protein calorie diet you can find, because they're going to eat smaller amounts. So give them as much nutrition in the smallest bite that you can. Their mouths get all eroded, so make sure we don't give them foods that's going to upset it. And it's actually GI, mouth to anus. They could even get hemorrhoids and, their anus, really sore. And that would be that sitz bath. And again, neurological problems. Now, neurological problems, why? Leukemia has pain medicine, bearing down, platelets are low, hemoglobin are low, chances of bursting in the brain can happen, right? Just think of those all together. So one of the things that is to watch for is that constipation. Sometimes the urine starts to get blood in it too. Again, making sure they have as much fluid as you can if they're going to for you. And of course, hair loss. That's, the common, in this case, and especially little girls. I was the nurse who had these little rolls of ribbon. I had them in every color. I used to go to Walmart, and every time I'd pick up some. And I'd make little headbands and put little, 6 different colors and have it on the side of their head. And I'd wear the same thing all day. And you know something? They didn't care they didn't have hair, or they were losing hair because they had a really cool ribbon, just like the nurse, right? So there's things you can do for that distraction. Another thing we give is steroids. Remember, this is higher dose, longer period of time. It can cause Cushing's. So make sure that we keep these kids comfortable in the clothing they wear and just be aware of it. So procedures, again, I said usually they are going to be sedated. Again, getting on their level, developmentally appropriate explanations. Of course, anything that you're sticking, sure that you numb it. Decreasing the amount of pain is what we want, and making sure. And I've had to sometimes, no, you're going to do a deep infiltration. Here, here's a lidocaine, and say, doc, now do it. Because sometimes they forget. It's what we're nurses for, to tell them. And pain medicine management. Pain medicine isn't just morphine. It's also acetaminophen, ibuprofen. It's also ice, heat, moving, distraction, all of those things. And they actually say that giving low dose around the clock is actually the best thing to do with it, and making sure that they have enough of what they need. With kids that are, with these low white counts and immunosuppressed, immunizations are still a life of a young kid. We're still going to be giving them. So just be aware, we can't give live viruses to these children, okay? And one of the things that's very dangerous, and why I say you see a kid who you think is chickenpox, please protect yourself and get that kid put away, because um, there is a child that could have immunosuppression, and it could be very dangerous to get varicella. And they also say, can the family get them? Because remember, they're around them. Yes, some of them, but not all of them. Now, lymphomas, pay attention. 50% are always wrong on the exam on this question. So let me explain it to you. There's non-Hodgkin's and there's Hodgkin's disease. Now, Hodgkin's, this is a lodge, a house, okay? It's large and you can touch it. It is, the lymph nodes get big. In Hodgkin's disease, it's above the clavicles. So you're going to see these neck with these distended, painless, big distended lymph nodes that start to push against the airway. You'll see the kid maybe coughing. And then, of course, signs of cancer, fever, anorexia, weight loss, and night sweats. So Hodgkin's, it's a house. I can see it, I can touch it, I can feel it. Hodgkin's house, right? A lodge. It's, something that I can feel it. They'll be doing, of course, the CBC. They'll be looking for all the inflammatory factors on it. And because it's so big, it's easy. They'll take a nummet and they'll do a biopsy, of course, under some sort of sedation. You're going to find Sternberg Reed cells in it. They do radiation to shrink it, chemo, sometimes yes, sometimes no. And then that actually will get rid of it. Long term, it's very good. It is a cure. One thing about this is with the chemo and the radiation, there's a high risk of infertility with these children. Now, non-Hodgkin's is not a house. You can't see it. You can't touch it. It's diffuse. It's tiny. It's everywhere. And it's not in the upper. It's spread out through the whole body, okay? So the difference, Hodgkin's, big, large, you can touch it. Non-Hodgkin's is everywhere, okay? Now, we do the same sort of things on it. We're going to be doing a biopsy and all sorts of scans, making sure that there's no metastasis on it. And this one is going to be getting chemo. If we can find little areas to irradiate, yes, but mostly it's a chemo on it. And again, this one is a little harder to cure. Now, brain tumors. It's the most common tumor in children. What would you see with a kid with a brain tumor? There's this space occupied in the head that's getting bigger. you're going to see headaches progressing, getting worse over time. The pressure in the head, vomiting, not related to eating at all, and getting worse over time. Maybe gait changing, falling down, those things. So you might see swelling on the infants, because infants can get brain tumors. So hydrocephalus, water in the brain, headaches, vomiting. Then the eyes can be affected depending on where that tumor is. Walking, the ataxia, just not right. And then diabetes insipidus is the pituitary gland, getting pressure on it, causing urinating and being thirsty. And your growth will definitely be affected by it. So what do? Well, number one, they just do an x-ray. They find this white thing in there and they go, okay. Then they do CT, they do MRI, they do all sorts of imaging to find out where it's at. And as long as there is no increased intracranial pressure, they'll do an LP, make sure there's no tumors in, again, the spinal column. And if they can do a biopsy, they'll do that to determine what they're going to do, what's the treatment. So with brain tumors, it's scary on parents. You know, they've got these big incisions on the head. Sometimes they can shave half a head, sometimes the whole head. But their brain drains in there. And it is scary. They'll do a radiation, shrink it. We want it the smallest piece of brain we have to remove, and chemo, okay? I mean, we would like to get that tumor out and have no deficits with speech or memory or walking or any of that. So post-operatively, these are difficult children to work with, because can you lift the head of their bed? Can you elevate it? Can you turn them on the side? Well, this side had the tumor. Do I turn them on this side? Do I turn them on this side, right? Most of them have brain drains in there. Do you touch it? Don't you touch it? And what affects the brain and the pressure? Fluid balance. So strict intake and output. And you do not want to over give fluid on these children and put more pressure into that brain. The next one, and I'm just going to mention it briefly because it's really not a lot of children. It's called a neuroblastoma, but it starts with a mass in the abdomen. And before we know that it's there, it's already in the brain. So outcomes are not great. You've got a brain and an abdominal mass that you have to remove. So just know that these children, before we even know that they have a tumor in the brain, it's already metastasized. So what they do is with these children, they will do the surgery, you know, chemo, radiation, and they're going to try. Outcomes are depending how big is that tumor already. Now, bone tumors can happen. You know, when I think of bone tumors, I think of an osteosarcoma. Now, osteosarcoma, bone tumor, what you're going to see is usually there's pain, stiffness, limping, especially in the morning when you just get moving. As it grows, you might be able to feel it. And then as it goes on, you might see a fever, and it might also go into your lungs too. So respiratory distress. Bone tumors can be cured, but the quicker that we find them, the better. Usually these kids come in, they're limping, their leg hurts. They'll do an x-ray and we'll see fuzz on the side of the bone. You know, if it's gone on long enough, we'll see him they'll be anemic. It's a cancer. It likes red blood cells. And then weight loss, because now they're tired, they're not eating good. And it's eating white blood cells, infections. So we do an x-ray, CAT scan, MRI, biopsy if we can, find out what's going on. Now, what do we do? Now, the femur bone has a tumor on it. You can't just remove a tumor. the whole femur bone must be removed. So if you remove the femur bone, you left the hip with nothing to put in the socket, right? How is this child going to be mobile? They actually take, and it's called salvaging the limb, the lower leg, and they insert it up backwards into the hip socket. And why? Well, now they have a place to put a prosthesis and they're able to be mobile. Could you imagine having a leg and the other one with the foot backwards? Try to explain that one to your girlfriend, right? A lot of times these are adolescents and a lot of times they're boys. Wilms tumor. This is a renal or a kidney tumor. And it's boys usually that we see it in. And it's something that you don't see unless you've done an examination and find it, or it's gotten so big and now you can't miss it. I had one case in my whole career, and I don't even know why I remembered the name Wilms tumor. We had a boy that after the Haiti earthquake, the hospital went down there and they found this boy. And they got a religious group to bring him up to Miami airport. They picked him up and they were told to bring him directly to my hospital where I was the triage nurse. And it had the records with them. They were all in French. I couldn't read them. So I'm like, why is he here? And they go, I don't know. So what did I have to do? I did a really good physical exam. I'm talking to a boy who's French. I'm like, I don't speak much. Je parle un petit peu. It's about all. And comment allez-vous? So anyway, somehow I got on his level. I got him giggling. I took his vital signs. I listened to his heart. I went to listen to his abdomen. And I found a big softball sized tumor in his left lower quadrant. And I went, oh, it's a Wilms tumor. And I was right. So what do? Well, they had to find out, and identify it. They did an ultrasound and a CAT scan, and they found that, yes, it is a Wilms tumor. Well, the one thing about this tumor, it's very fragile. And if you touch it a lot, little pieces fall off and it metastasizes within your abdomen. So you don't touch it. Do not palpate abdomen. To be a sign on the bed, sign on his forehead, sign on the chart. Do not touch that abdomen, okay? These children, we do chemo, radiation, maybe, but surgery. They got to get it out. Now, they go through the belly, but where is the kidneys? It's in the back. So you have to go through all the intestines. So you worry about your intestines, and we're worried about, obstructions when they're done, right? They're also, it's a tumor on the kidney. So you're worried about urine when this whole thing is done. So we take it out as quick as we can. We watch their bowel function. We watch their urine function. This little boy did well. And this boy actually found someone to write the nursing unit that he stayed at a note to say that he was doing great. So this little boy's going to have a life now because somebody found it and we were able to do surgery, get him here. Now, a tumor on the retina, retinoblastoma. I've seen one. It was an 8-month-old little girl, and you actually see a white glow in a pupil. It's like seeing an animal in the dark with a light on. You see those little shiny white eyes. That's why we call it cat's eye. Sometimes we call it. It's a whitish glow. One of the things about retinoblastoma is that if we see it, we need to question, has this kid any eye problems? Have you seen any drainage? Has anything gone on? You need a really good assessment about that. Now, they do a radiation. They try to shrink it, making sure it's not out of the eye socket, right? And they do chemotherapy. And remember, anytime they put these little marks, these purple marks for radiation, that we do not wash them off, because that's exactly where they're going to point the machine next time. And if you wash it off, they've got to remeasure. So again, find out what's going on. They take the whole eye out. And these children do end up with some sort of prosthesis eye. Another tumor is, women do breast exams. Men should be doing testicular exams monthly. 18-year-old boy came into the ER complaining of testicular pain. The other nurse in the triage area did an inspection, and it was this huge, again, tumor. When they went in and did the ultrasound, they found out it was huge. They did an x-ray of his chest and abdomen. It already metastasized everywhere. That 18-year-old boy died in 3 months after we saw him in the ER. So testicular is a big thing. Make sure you check yourself. Liver tumors. Well, what's great about livers is you only need a piece of it to work, and they regenerate, right? So usually you do chemo, you remove it out. These kids do actually pretty good. So cancer today, this book is older, so I'm sure it's even more than this. I've seen such incredible strides with chemo and the treatment and decreasing the length of treatment, et cetera. And it works really, really well. Just remember, kids with cancer, they're still kids, you still got to keep them up with their growth and development and making sure, that they're getting everything they need. Cancer is a hard thing to deal with. And remember, parents and siblings, they're all involved with it. I love these little things posted on Facebook, cancer free, and that child's gone through a lot to get there. Any questions? All right, let's start our cahoots. Let's see how far we can go. I'm not going to keep you till you guys fall asleep on me. You know me, I wouldn't do that. Who wants to win tonight? Libby wants to win. You always do. Mara likes to win. Oh, Kimberly. Uh-oh, watch out for her. Watch out for her. She's a sneaky one. Teasing Kimberly, you know that. Getting something to drink quick. All right, here we go. Week 6, almost done. We're over the hump. Going on the down low now. Which statement best describes a neuroblastoma? What did I tell you about that one? The thing says neural, right? But remember, it starts in the belly, and then it gets bigger, crosses the midline, and it goes in the brain, and then sometimes it even goes and you see the eyeballs starting to pop out on it. Again, this is a diagnosis is always made after it's already metastasized. That's the big thing. It's very hard to treat. What is priority treatment for a newborn of HIV positive mother? Does HIV positive mother mean this baby is? So remember, our goal with infants is to boost their immune system, Give them every fighting chance to get rid of the disease. And I'm telling you, many times it does work. What are symptoms of sickle cell anemia? So hand, foot, pain, vision, delayed growth, all of those things. Remember, it's pain, swelling, heat, and these kids, fever, low hemoglobin, hematocrits. They're sick kids when they come in. Sickle cell anemia affects which cells? And it is absolutely your red blood cells. I make sure that you know that. You'd be surprised. What kind of hematocrit would someone with sickle cell have and why? Where is their hemoglobin hematocrit? What did I tell you about sickle cell children? What's the normal? So your hemoglobin hematocrit's lower because the cells die quicker, right? So your hemoglobin hematocrit are a lot lower. I tell you, they always, always, always come in when they're in crisis with an extremely low hemoglobin hematocrit. I'm telling you, if they're 7, I'm happy. But many times they're 5. I actually saw one child with a 4. That one scared me. What is the treatment for sickle cell anemia? IV fluids priority, dilate those vessels, right? They're going to need blood transfusion. And then, of course, that bone marrow is possibly a cure for it. What is the reason children with iron deficient anemia are easily tired? This is a big concept here. So, in iron deficient anemia, you don't have red blood cells. Red blood cells carry iron and oxygen to the cells for food and energy. You don't have red blood cells, you're tired. You don't have energy, you don't have food. Aplastic anemia includes a depression of which blood cells? Pancocytopenia. So again, A is always without anemia, right? Remember, A is always a without something, like atresia in the cardiac, right? So red blood cells, white cells, platelets. Think about hemoglobin, think about infection, think about bleeding, all of them. That's how you remember aplastic, without. They got all the withouts. So triple whammy. Most common type of anemia is iron deficient anemia. Yes, very good. What causes pernicious anemia? It's another word. B12 deficiency, intrinsic factor. Yes, very good. What symptom is the single most common symptom of anemia? I mean, that's a list of all of them, but which one is the most common? N, that's fatigue, being tired, complaining. Oh, I just have no energy. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for what? Remember, beta thalassemia, square cells, they burst, oxygen and iron are spewed. So they don't have oxygen, they're hypoxic. And iron is in their system, and now an iron overload. That's how you remember that one, okay? Rectangular shaped spews. Thrombocytopenia is ITP, immune thrombocytopenia purpura. What lab values will you see with hemophilia? So remember, yes, you can see all those factors. What are some things that you would see, quickly? That these labs come back really quick. And that's the PTT, which shows bleeding is long, but the PT are fine. And the platelets are normal. It's that PTT is prolonged is what you would look for. Priority treatment for a child with a sickle cell crisis. What do you do first? Priority. I mean, you can do all of them. Priority, fluids. Why? Dilate the vessel. That's the cause. They're too small. Blood cells can't get through. Dilate it, heat it, and now we can get that clump of cells away and decrease the cause of the pain. What is immune thrombocytopenia purpura? ITP. Remember, ITP, think P platelets, decrease platelet counts. Remember, usually following an upper respiratory or an infection, and it's not enough platelets. Not enough platelets, you're going to bleed. Ecchymotic areas and purpura, right? Thrombocytopenia can cause the following symptoms. And it's that petechial hemorrhage, ecchymosis, epistaxis. These are all bleeding symptoms. Platelets low, bleeding. What are they? That's the ones that you see. Multi. A child with hemophilia has fallen. The knee is swollen and painful. Treatment would include what? So we're not going to exercise. We're not going to give heat, which will make it bleed more. We're going to elevate it, put cold packs on it, and we're going to contain it, and we're going to rest, and we're going to calm that child down. If we're at home, they're hemophiliac, we're going to give a factor. Very good. What is a priority nursing action for suspected blood transfusion reaction? So you get the sickle cell kid in, they need blood, you're giving it, you're going to immediately stop the transfusion, right down to the hub, change the tubing and everything, and send it back to the lab. Very good. A child is admitted with neutropenia. Which nursing action takes priority? Neutropenia, what's that? Isn't neutropenia something about neutrophils? What do neutrophils do? Hand washing, hand washing, hand washing. Neutropenia is, any child you're worried about infection. It's always hand washing, wearing gloves. They do not have to be on any isolation. It's hand washing. Taking care of that. Which symptoms would a healthcare professional expect to see in a child with leukemia? What did I tell you about my neighbor who went, same classic signs? It's that bruising, fatigue, bone pain, fever. Yes, very good. Your child with ALL had recent lab results with platelet counts of 10,000. What is your nursing action? I mean, any child that gets lab results, platelet counts of 10,000, what are you going to do? It means this child is a potential for bleeding. You're going to put on bleeding precautions. That adolescent girl wants to shave her legs, you take the razor away, right? These are things that we would do. Very good. A multi. A child is placed on bleeding precautions for ITP. What interventions would the nurse do besides taking away that razor? No injections, look for bleeding, monitor the CBC. We're looking at the platelet count every day. And of course, corticosteroids if it's not getting any better. All of the above. You need to know that one. Child with Wilms tumor. What action by a nursing student causes a faculty member to intervene? That means, what is that student doing that's wrong? And she's touching that belly. Leave it alone. It's going to break off and it's going to metastasize. Very good. Cancer of the body's blood forming tissues, including the bone marrow, is what? Body's blood forming tissues. Cancer. And that is leukemia. A child with ALL has a fever of 100.5. What should they do? And this is the one that any child immunosuppressed with a fever, they need to call their healthcare provider or seek medical attention. Remember, ALL, they have no immune system. They need something to help because they now have a fever. They can't fight it. There's nothing to fight. Get medical attention immediately. Yes, they're going to be giving an antibiotic, but you've got to get the doctor to order it. A child's having a bone marrow aspiration. What should you tell the child? You know, I've seen several of these bone marrow. I've seen it done in the chest and the sternum and the hip. And there is this crunch, crunch, crunch that they do. It's like, oh, yes, it's going to hurt. And be honest. Most common clinical manifestation of a retinoblastoma, cancer of the retina. And it's called a cat's eye reflex. It's that white shininess like you would see on an animal, you know, in the distance when you turn the light on at night. You see a cat, a dog, a deer, or whatever. It's shiny. That's what it would look like. Your child's been diagnosed with a retinoblastoma. What information is important? What do you need to ask? So, has anything been going on with that eye? So, you need to collect as much information that we could figure out what has gone on here or how long it's been. A goal of surgery for a child with osteosarcoma is. So you see the osteosarcomas on that femur bone. What is the goal? Our goal is to try to take the lower leg and connect it up. They have to take the whole femur bone out. Now, sometimes they just have to do an amputation. There's nothing they can do. But our goal is to try to salvage it. We want something to put a prosthesis on to keep that child, and they're usually adolescents, to keep them mobile. True or false? Immunizations causes autism. Answer is absolutely not. The doctor who wrote up that article that was false is no longer practice. A child's complaining about the skin markings for radiation therapy. Should be told what? What should she do with those markings? Leave them alone. They are there. Tell her that's where they put in the medicine. The beam goes in there and kills those little cells. Leave it alone because they don't have to remeasure. A multi. Nursing care of a patient with immune thrombocytopenia purpura, ITP platelets, making sure that you know it. And there's a little bit of trickiness with this one because why are you giving IV fluids? The IV vessels are not clogged. Sickle cell disease, you need to dilate them. This is just platelets are low. The vessels are fine. There's nothing clogged. So, not IV fluids, everything else. Remember that. When distraction is used in pain, it helps what? You always see me throw questions from the last weekend here. See how many we have. So it shifts their mind away. They're not going to think about it. And it works so well. Be creative in how you distract. What assessment question needs to be asked to a child with possible rheumatic fever? What is rheumatic fever? How do you get rheumatic fever? What are you worried about with rheumatic fever? It's probably a strep throat. The biggest concern is the mitral valve damage. Once it's damaged, it is. Everything else, all the other symptoms will be cured, and that's by giving long-term antibiotics. Signs and symptoms of asthma. And coughing, shortness of breath, and remember, it's expiratory, right? Wheezing. All of the croup is all the inspiratory upper. Yes, asthma expiratory. Excellent. A multi. What symptoms should be reported to the healthcare provider for a child with sickle cell disease? So remember, headaches could absolutely be a stroke, and chest pain could be a myocardial infarction. Those are the ones that we are concerned about. Now, swelling of the hands and the sores, yeah, but what we're talking about, these ones are more emergent. Tell them right away. Absolute contraindication for nasotracheal suction include which of the following? When shouldn't you suction the mouth? Anything to do with upper airway, epiglottitis, croup, tonsillectomy, you don't want to create more swelling or bleeding. All the above. Iron dextran is given via which route? We use it for iron deficiency anemia. Some of the children don't like that liquid or won't eat, or maybe their iron levels are so low we need to give something else. And it's IMZ track because it burns and it stains the skin. Very good. A child's to receive their own bone marrow. This is called a blank transfusion. Automatically mine's the best, autologous. All the others, everybody else is allogenic. Very good. What cancer may present with painless, firm, and enlarged cervical nodes? Big nodes here. Remember, that's a house, it's a lodge, it's a Hodgkin's. It's upper, above the shoulders. That's Hodgkin's. lymphoma? A multi. When teaching about sickle cell disease, you would include what? So dress warm to keep the vessels open, pain medicines early, and of course, they're immunosuppressed. Make sure they get medical care for fevers 100.5 and higher. Thalassemia major, Cooley's anemia, is treated primarily with. They also have facial deformities. Their bones tend to be enlarged in the marrow. And that's actually what a child would look like. So thalassemia, rectangle, they burst, and they're only treated with blood transfusions. Very good. A multi. What are opportunistic infections of HIV? So candida yeast and your PCP pneumonia. UTIs, rashes, we don't consider those in pediatrics. A multi. Treatment of an osteosarcoma includes bone cancer. And, for all purposes, they do talk about osteosarcoma and femurs. So you either amputate it, you give chemo, and you want to salvage the limb. Stem cell transplants, not in this case. Treatment is radiation, chemo, and these things right there. A multi. Who are the best donors for bone marrow transplantations? This is your donor. It's all the others. What's the best? Right? Best? The best person? So first of all, it's yourself. It's usually cord blood is where they get that from. And then siblings. All the others, that is your best one. Mom and grandma, they're half of what you need. It's mom and dad together. That's why it's a sibling. What is the most common opportunistic infection for children with HIV? Most common. We know there's a lot they get. What's most common? And PCP pneumonia. That is number one. What would you consider to be neutropenia or a low neutrophil count in children? And that's at 500. Remember, child with neutropenia, neutrophils 500 with a fever is going to go into septic shock. This is a child that if you're given a group of patients, this is the one you should see first. This one is the one that could give you most problems if you don't get in there quick and start treatment. A primary characteristic of a brain tumor is symptoms becoming worse over time. Vomiting is not related to anything. Headaches are getting worse and they're not just occasional. And you could be falling over, depending on where it is. The optimum treatment for osteosarcoma is what? What is the best thing you could hope for? I think we've heard it enough now to understand. It's salvaging that limb. You can't just remove the tumor. In osteosarcoma, the whole bone's got to go. You can't just scrape off the piece, okay? So always the whole bone. And last question. A child is receiving the induction of chemotherapy. What does that mean? And that's the initial chemo, and the goal is remission. Now, there are 3 more steps after it, but it's the intense part. And usually the cells are gone, but there's going to be a couple hidden. That's why they keep going. Hey, we made it. Kimberly, I told you Kimberly'd be there. Libby, there you are. Good job. And Haley, good job, Haley. And Kirsten and Bree, good job, guys. So week 6 is done. We know that this week is all of their reviews. If you can make a live review, that's always good. If you can't, remember, I do put them in one announcement, and I do update it and edit it so that you will always have all of it in one place. Okay. You don't have to look at 4 different places for your reviews. One place. You have your Cahoots there, you have your study guide there, and you have all of the recordings, trying to keep you as organized, because 3 classes, everybody loves the sound announcements. And you're like, which one do I read? Which one don't I? And I understand that. I don't send a lot. I think you've seen that. So anyway, good luck, everybody. I see you all next week. If you have any questions or you need to see me before the exam, just let me know and I'll work with you. Have a good night, guys.
Thank you.
My pleasure.